Hi guys, we will talk in this video about idiopathic pulmonary fibrosis, and the name idiopathic is relating to or denoting any disease, and especially a pulmonary fibrosis in this video, which arises spontaneously or for which cause is unknown. So also, pulmonary fibrosis have other causes, and if the cause is unknown, it is called idiopathic. What are the objectives of our video? So, identify the presentation and pathological progression of idiopathic pulmonary fibrosis or IPF. Review typical presentation findings, including laboratory and diagnostic imaging. Outline the treatment and management options available for IPF, including the newer anti-fibrotic pharmacologic agents, and explain possible interprofessional team strategies for improving care coordination and communication to advance the evaluation and treatment of IPF and improve outcome, of course. Our introduction part, like idiopathic pulmonary fibrosis, is a lung disorder that is characterized by scarring of the lungs, and it is from unknown cause of or origin. It is a progressive disease with poor long-term prognosis, and classic features include like progressive dyspnea and non-productive cough. Pulmonary function tests usually reveal restrictive impairment and impairment of diffusion capacity or diminished carbon monoxide diffusion capacity, as it is measured by carbon monoxide. On CT scan will reveal some peripheral distribution of bilateral fibrosis and more pronounced at the basis. And the treatment includes supportive measures, oxygen supplementations, when needed, anti-fibrotic drugs, and lung transplantation. This slide is general and can be used as main one. What is the etiology of idiopathic pulmonary fibrosis? So by name, it is unknown, but can have risk factors like exposure to tobacco, smoke, metals, wood dust, and also gastrointestinal reflux have been implicated. And the recurrent injury of the alveolar epithelium triggers a cascade of signaling by the immune system that lead to fibrosis. A dysregulated response of inflammation to the injury can cause a tissue remodeling and transformation from normal tissue to fibrinogen or collagen. Also, genetic mutations like telomerase genes, surfactant genes, and mucin genes can be involved. Presents usually after the 50s and 60s decades of life, and is more common with older age. And in US, prevalence is estimated to range from 10 to 60 cases per 100,000. Pathophysiology, so environmental factors like smoking, chronic aspiration, or viral infections, along with advancing age, can lead to respiratory alveolar epithelial injury and are thought to be the likely driving factors for pathogenesis. And when the epithelial is injured, there is an activation of fibroblasts and dysregulated repair of the alveolar epithelium, which will lead, of course, to increased matrix deposition in the lung interstitium and scarring. There is a destruction of lung architecture later and result in pulmonary fibrosis. So destruction of lung architecture impairs gas exchange and will progress to hypoxic respiratory failure, a hallmark of advanced disease. advanced idiopathic pulmonary fibrosis. Histopathology is non-specific and reveals heterogeneous zones of the normal and affected lung. Interstitial inflammation, honeycomb change, and fibrosis are common. So these changes can be seen with other forms of advanced lung disease. To make a diagnosis histologically, the following should be present. So presence of foci of fibroblasts, evidence of honeycombing or a disruption of lung architecture, patchy involvement of the lung by fibrosis. And important is that absence of other features suggesting an alternative diagnosis. So no other features which can plan for other diagnosis. The most common presenting symptoms which have patients are dyspnea on exertion and cough, and followed by fatigue, and also history of exposure to inhaled dust, metals like asbestos, molds, birds should be elicited to exclude other interstitial lung diseases. As we told previously, that idiopathic is from unknown origin or unknown cause, but if you know that patient was exposed to some dust, asbestos, birds, or anything like that can produce fibrosis, it's another type. It is induced by different causes. Also, medication and drug history is important to exclude drug toxicities. Exclude also autoimmune conditions like rheumatoid arthritis, scleroderma, Sjogren's syndrome or disease, polymyositis or dermatomyositis. All of them should be excluded. And you have to know that cough is the most commonly dry and non-productive. Non-productive dry cough for a long time. The physical exam should be focused on evaluating lung involvement, extent and severity of the disease, and excluding another diagnosis related to pulmons. The classic pulmonary exam usually reveals fine by basilar velcro crackless during inspiration. Clubbing at nails and distal phalanx may also be present. To exclude autoimmune conditions, evaluate for skin rashes, joint swelling, sclerodactyly, Raynaud phenomenon, and muscle weakness. Evaluation. So pulmonary function test should be performed and is characterized by decreased lung volume. So decrease in forced vital capacity, decrease in total lung capacity, decrease in functional or residual capacity, and also decrease in diffusion capacity of gases. And chest CT or high resolution CT reveals usually interstitial pneumonia, bilateral, subpleural, basal predominant honeycombing or traction bronchiectasis, or simply bronchiectasis. Peripheral reticular opacities are usually most notable in the lower lobes. Histopathology confirmation is not always necessary, but should be considered to exclude other conditions. Characteristic histopathologic features usually interstitial pneumonia pattern, which indicates the presence of temporal and spatial heterogeneity, the presence of fibroblastic foci, areas of subpleural honeycombing, and interstitial inflammation. Important point is that there should be an absence of other features like granulomas or giant cells to exclude other conditions. You have many pictures in front of you. So this honeycombing like structures, and you see here what mean honeycomb. On the right side as well, you see these structures on bilateral sides. As fibrosis develops on both sides of the lungs and not only on one region usually. Treatment, finally, antifibrotic agents which are approved for use in idiopathic pulmonary fibrosis, pirfenidone and nintedanib, which are tyrosine kinase inhibitors. They only are approved for treatment and shown some benefits in studies. Also recommended supportive measures like tobacco cessation in smoking patients, oxygen supplementation, and control of gastroesophageal reflux with proton pump inhibitors. In elder patient, you can recommend some vaccination for influenza and pneumococcus. Corticosteroids, immunosuppressants like azathioprine and acetylcysteine have been used in the past, but now the recommendation is against the use of these agents in idiopathic pulmonary fibrosis following a publication of the Panzer IPF trial, which demonstrated that it's not beneficial. Referral for a lung transplant is recommended yearly in the course of the disease, especially in patients with progressive decline in lung function. And survival benefit has been shown for patients who undergo lung transplant. But lung transplant is not as simple as could be, and is not done for every patient with idiopathic pulmonary fibrosis. Also, make a good diagnosis of comorbidities that may be present, like coexisting emphysema and pulmonary hypertension, smoking history, low body mass index, and older age are associated with worse prognosis. That's a pity. Differential diagnosis should be done with other types of fibrosis, and especially causes like occupational lung disease, pneumoconiosis and asbestosis, aspiration pneumonia, bacterial or viral, any type of pneumonia, farmer lung from birds and chickens, fungal infection, lung cancer, pneumocystic pneumonia like pneumocystis jirovecii, sarcoidosis, pulmonary edema, and connective tissue diseases like rheumatoid arthritis, for example. Complications that could accompany idiopathic pulmonary fibrosis are pulmonary hypertension, thromboembolic events or thromboembolic disease, adverse effects of medications, superimposed infections, acute coronary syndrome, and hypoxic respiratory failure, which is developed often in patients with IDF. And outcomes, so a poor prognosis for patients with idiopathic pulmonary fibrosis with a mean survival of 24 to 30 months, which is worse even than a diagnosis of non-small cell cancer, cell lung cancer. Most patients have continued dyspnea and limited exercise tolerance from dyspnea, which is a resultant of a pure quality of life. These are most common in the winter season and even in the absence of any lung infection. And many of these patients develop pulmonary hypertension and are at increased risk of pulmonary embolism and sudden cardiac death. Thank you very much for your attention. I want to mention that this video lecture is made only for study or educational purpose, and I have nothing to disclose. Have a good time, and if you would like to read by self This one you can type on internet NCBI article and idiopathic pulmonary fibrosis. Thank you.